Good afternoon, everyone, and welcome to the Missouri Board of Pharmacy's Lunch with the Chief webinar. This is Kimberly Grinston, Executive Director for the Board of Pharmacy. I wanted to welcome everyone and thank you for joining us for this call or for this webinar. Our title today is Opioid Dispensing, a Conversation Instead of a Sledgehammer, What to Do When You Suspect Opioid Misuse. As we look at the opioid crisis in the state of Missouri and nationwide, we believe this is a very timely topic. Not going to belabor the time. We're going to turn the program over to Dr. T. Meyer and Dr. Gable. Before we do that, Tom Glinsky will walk you through some of the logistics on the webinar. Once again, thank you everyone for joining us, and hopefully we'll have time for questions at the end.
Thank you, Kim. This is Tom Glinsky, Chief Inspector. Today's, as Kim mentioned, we have Dr. Amy T. Meyer. She's Associate Professor at the St. Louis College of Pharmacy, and Dr. Kelly Gable, Associate Professor at Southern Illinois University at Edwardsville School of Pharmacy. Before I turn it over to Amy and Kelly, just a few things. For people who have not been on our webinars before, you are in listen-only mode. You have been muted. If you have any technical difficulty and cannot get audio through your computer, there is an option on your toolbar to dial in using your phone to get the audio option. If you've been on our previous webinars, the CE for this one is going to be different. The board will not be providing the CE. St. Louis College of Pharmacy has this approved for ACPE credit. As usual, you only get credit if you are logged in to the webinar, and there's no computer sharing. You must be logged in individually. And St. Louis College of Pharmacy will email CE instructions out to everyone after the webinar. It may take a few days before you get that webinar, before you get that email. If you want handouts, they're on the board's website on the upcoming events tab. If you click that, there's the web page for this webinar, and they're now posted on that page. And we will also be making a recording of this, and we post our recordings of webinars on our web page also. If time permitting, we'll take questions from participants. If you want to send a question, go to your toolbar, to the question section, type it in and hit send. And at the end, we'll see what we have, if we have time for questions. So now I'm going to turn it over to Amy and Kelly. It'll be just a moment.
Okay, great. Thank you, Tom. Can you see our screen?
Yes, you're good to go.
Beautiful. Okay. My name is Kelly Gable, and again, as Tom said, I'm an associate professor at SIUE School of Pharmacy. I'm also a member of the Motivational Interviewing Network of Trainers and a consultant on the Missouri Opioid STR grant, which we'll talk a bit about in just a moment.
And I'm Amy T. Meyer, an associate professor at St. Louis College of Pharmacy. I'm also a member of the consultant on the Missouri Opioid STR grant. And we also wanted to acknowledge our third consultant member, Nicole Gaddis, who helped in the preparation of this presentation.
So we're glad you chose to join us for this 1-hour presentation. We feel like we have a very important stuff to discuss, and hopefully you'll have some good questions for us along the way. With regard to the content of this talk, we have no conflicts of interest to share. We are supported through the Missouri State Targeted Response to the Opioid Crisis Grant, which is Opioid STR, and that is a SAMHSA-funded grant. What we hope to accomplish over the next hour is to briefly describe the CDC guidelines for opioid prescribing, as I think it really kind of sets the tone for the rest of the dialogue that we have. We hope to describe key components to the St. Louis County PDMP and talk about the pharmacist patient care process for how we would approach someone with an opioid prescription where we suspect misuse, and then also identify ways to effectively engage physicians and patients surrounding opioid education and misuse. As a community pharmacist in particular, we believe that you have a dual responsibility, one of providing safe and appropriate access to opioids, but also protecting the public from opioid misuse and overdose. And we recognize that that can be a real challenge. And so we really hope to address some of those challenges over the next hour. This first slide really highlights the opioid overdose epidemic that we're living in today. And the reality is, if you can look closely at this, the line at the very top that goes all the way to the top is synthetic opioids. And so in particular in the St. Louis region, but across the country, we're seeing an uptick in synthetic opioid overdoses. And that is really what's driving the majority of the overdoses across the country. And of course, that includes street-made fentanyl and carfentanil. And then you can see that heroin by itself has maintained, and then also other opioids, including prescription opioids. The problem becomes when people are taking prescription opioids for perhaps a legitimate pain condition, and then they are stopped, and sometimes abruptly, people will navigate toward using street opioids or street derivatives to gain control of their pain. And that's when they're really at a very high risk for an opioid overdose. And so here on this slide, and we're only going to spend a brief amount of time talking about this, but this is really a brief overview of the CDC guidelines. The guidelines were developed to provide safer, more effective care for patients with chronic pain and to really help reduce opioid overdose. So we're going to highlight a few just within this hour. And number one, of course, opioids are not first-line therapy for pain management. And that's really outside of cancer pain, palliative care, and end-of-life care. And we really want to push this out there as an education piece for the public, which is critical. We really want to be looking at non-opioid treatment options for chronic pain. Moving into the use of immediate release opioids. So when starting therapy, we recommend now immediate release opioids over control release. And the reality is there's a higher risk of a potential fatal overdose with the control release products, in particular when starting off treatment. We also recognize that the best way to go about this is the lowest effective opioid dose. And you're going to hear time and time again that we look at that 50 morphine milligram equivalent per day or less. And we're going to talk more about what that means as we get to our patient case. We also say prescribe the shortest duration for acute pain. And we recognize now that oftentimes 7 days or less is really what we want to look at for acute pain. And for more chronic pain, we want to start looking at alternatives to opioid medication. And then for number 8, use strategies to mitigate risk. That directly refers to things like recommending, co-prescribing, and dispensing naloxone. And we'll review that again as we did in the previous webinar. We're going to talk extensively about reviewing PDMP data and what to do with that information, and how to have an effective conversation with information you obtain for the PDMP. And a big one on here, number 11, is avoiding concurrent opioid and benzodiazepine prescribing. And that is huge. And in talking to pharmacists across the state, we recognize that it's not uncommon to see opioid and benzodiazepines prescribed together. And so we really want to start that conversation of how do we start to reduce these numbers. And then offering treatment for opioid use disorder. And that can include buprenorphine or methadone. And so we want to be mindful of those treatment options and recommend them when they're appropriate.
So this is Amy. In addition to the CDC recommendations, we thought it would be good to quickly review some other factors that will impact how you assess an opioid prescription in your practice. So first, we'll talk about the Controlled Substances Amendment, Senate Bill 826, that went into effect on August 28th of this year. Those of you in community pharmacy are probably very familiar with this already, but this limits the initial prescription of an opiate for acute pain to a 7-day supply. So we're not talking about the chronic pain patient that the CDC guidelines apply to, but rather acute pain. And for that initial prescription, that is considered an initial prescription if it's issued to a patient who's never been issued a prescription for that particular drug or medication, or if it's been issued to a patient who has not used, been prescribed, or administered that medication within 5 months prior to the current prescription. If that quantity on the prescription exceeds that 7-day limit, that excess amount is considered void and cannot be dispensed. And this applies to all healthcare practitioners, excluding only veterinarians. There are some exceptions to this, recognizing that we need to be able to provide appropriately for patients in various settings and in situations. So if the prescriber does decide that a greater than 7-day supply is needed, they have to document what condition is requiring that extended supply, and that a non-opioid alternative was not appropriate. So very consistent with the CDC guidelines saying that if at all possible, a non-opioid medication should be used first for those chronic pain and for acute pain. Exceptions for this legislation include patients who are undergoing cancer treatment, those in palliative or hospice care, long-term care facility residents, and those who are receiving substance abuse or opioid dependence treatment, as some of those medications are controlled substances. Next, we'll talk a little bit about the St. Louis County PDMP. So the county PDMP launched in April of 2017. The website is listed there for you if you would like to get a little bit more information. It was the first locally based PDMP in the country. So we're all aware now that Missouri is the only state that does not have a statewide PDMP, but we felt locally here that it was needed to do something so that we could have a little bit more information about opioids and how they're being prescribed and dispensed. The Department of Public Health here in St. Louis County serves as the program administrator, and any Missouri jurisdiction may subscribe to the PDMP. So it was written such that other jurisdictions could join on. They monitor the prescribing and dispensing of Schedule II to Schedule IV controlled substances, and the goals are a couple of different things. So they want to improve controlled substance prescribing by providing critical information regarding the patient's prescription history. They want to inform clinical practice to help practitioners identify patients who are at high risk who would benefit from interventions. And they also want to reduce the number of people who misuse, abuse, or overdose, and making sure that patients have access to safe and effective treatments. If we look at a map, this map is from the end of August, and we've had a few counties and cities who have joined on since this map was created. But this map shows all of the different jurisdictions that are participating in the PDMP. Currently, as of today, there are 71 jurisdictions that are participating, and this covers 84% of the population in Missouri living in one of those counties or cities. They continue to have rollouts and jurisdictions that are joining. So just recently, just a few days ago on December 1st, we were happy to have Crawford County, the city of Osage, Phelps County, and Pikes County all go live and join in. And then looking into 2019, Warren County, Camden City, Ripley County, and Dent County are all scheduled to start. So for those of you that are in those counties, you can be looking for information regarding that, and you can start using the PDMP soon. When we look at those who are using the PDMP, obviously the greatest percentages are for physicians and pharmacists. Physicians, a little bit more than doubling pharmacists, but we also have a small number, actually dentists and podiatrists and optometrists. The other is some miscellaneous folks like law enforcement and other factors, folks, and then delegates. So the delegates include healthcare professionals such as nurse practitioners, physician assistants, medical residents, pharmacy interns, dental hygienists, etc. So they can be a delegate user underneath an approved user within the system, such as a pharmacist or a physician. When we look at daily use, when it first went live, there were about 690 patient searches per day, and as of July, there were an average of 4,335 patient searches per day, and that continues to increase. And then the county has done a great job of providing a lot of different data on this to really analyze and see if we can figure out where some of the problems are. So you can see opioid dispensation rates by the primary opioid ingredient, and you can also see dispensation rates per 100,000 population by jurisdiction. So if you're interested in your area to see what those rates are, you can find all of that information on the St. Louis County PDMP website. Just to give you a little overview if you're not familiar with or haven't used the PDMP, this is what the provider dashboard looks like. So when you sign on to the PDMP, this is an example of what you will see. And the recent request includes not only the patient's that you have looked up, but also any patients that any of your delegates have looked up. And so you can see that information there, when the request date was, and et cetera. When you do a patient search, the minimum search criteria that is needed to do a search is the patient's first name, their last name, and their date of birth. There are optional additional criteria that you can add in there to filter down your results a little bit, but at the minimum, you need that first name, last name, and date of birth. And then for the search period, the default is always going to be the previous 12 months. However, that can be shortened or extended up to the previous 24 months. And then when you do get a report on a patient, you'll see a screen similar to this. If there is a concern, if it trips what we call our multi-provider alert, you will see that alert with a red triangle with an exclamation point at the top. And that is generated when a patient has controlled substance prescriptions written by 3 or more prescribers and filled at 3 or more pharmacies within a 6-month period. So it is important to keep that in mind. This is not a fail-safe in figuring out who might be at risk, but it is an alert. But there may be people that there is not an alert for that you would need to pay attention to their prescribing history as well to see if there is concern. There's going to be a report summary that shows just some general summary information, and then you will have the prescription information, the prescriber information, and the dispenser information as well. So you can see all of those different factors for each controlled substance prescription that the patient has had filled in Missouri in one of those participating jurisdictions. So this PDMP gives us a lot of information, but what do we do with it? So as many of you may have heard, and if you haven't, this will be a good first introduction, but this is becoming more and more prevalent, that we are now using the Joint Commission of Pharmacy Practitioners pharmacist patient care process and how we assess and interact with patients and provide patient-centered care. So as you can see, this is a process that looks at a variety of different evidence-based practice principles, and going from collecting information, assessing that information, creating a plan, implementing the plan, and then monitoring and evaluating, and then going back to follow up with that patient and going back to collecting information, and that continuous loop for providing care for patients that is centered around collaboration, communication, and documentation. So let's go ahead and put this in context of an actual patient case. So first, we're going to collect some information. We need the necessary subjective and objective information about the patient in order to really understand and fully assess. So as that first step, we do need to collect the information. So we've got Jack, and this is our patient, Jack. He's a 30-year-old male. We've got his contact information, his address, and his insurance information. And he hands us a prescription for oxycodone 5 milligrams. And we ask him a few questions. And in talking to him further, we discovered that he was in a car accident. He's got a neck injury as evidenced by the brace around his neck. He's never heard of naloxone before, and all of his meds are filled at the pharmacy that you're at. So some things to think about when you're getting that initial opioid prescription at the pharmacy counter, especially for patients that you're not as familiar with, but even the ones that you are, you want to ask and note what type of pain is being treated. Do you anticipate using that medication for more than 3 months? Did the physician discuss how to stay safe while taking this medication? Did the physician discuss naloxone with the patient? And what other medications are you taking, especially if the patient uses multiple pharmacies? That can be critical information. So once we've gathered that information, we'll want to assess that information. And one thing to note is whether or not we check the PDMP now or later. And that really is dependent on the workflow of your pharmacy and how prescriptions are processed, how busy you are, those kinds of things. You will need to check the PDMP at some point, or we would recommend that you check the PDMP at some point if you have it available to you, just to make sure that you have a complete picture. Maybe the patient forgot that they had an emergency fill while they were out of town, or the pharmacy was closed and they needed to get it filled somewhere else. So even when you do know that patient, it's always a good idea to take a few minutes to check that PDMP just to make sure that you have full and complete information for that assessment phase. So in that routine prescription verification that you're doing, you're going to want to evaluate the medication profile and the PDMP data, if you have it available, to identify their risk factors for an overdose. So is there duplicate therapy? Are there multiple opioid medications on the profile or that the patient is potentially taking that could put them at risk for an overdose? They may not realize that they have multiple opioids. Do they have pain prescriptions from multiple prescribers? They may be legitimate prescriptions, but those prescribers may not be aware of each other in those prescriptions, and that could certainly put the patient at risk. Next, as was mentioned in the CDC guidelines, opioid plus benzodiazepine use is a huge risk factor for overdose. And then there's multiple chronic conditions, especially sleep apnea, COPD, cardiac disease, HIV, and some renal or hepatic dysfunction that all change the way that opioids are processed or decrease the body's ability to manage and compensate when there is an increase in opioid in the system. And so those things put those patients at much greater risk of having an overdose. And finally, chronic opioid use or greater than 50 milligram morphine milligram equivalents per day. So one question is, well, how do we calculate that morphine milligram equivalent per day? And you can find this in lots of different places, lots of different sources for this information, but really you're going to take the strength and then you're going to look at the product of your units over your day supply and then apply a conversion factor. And you can find this anywhere on the internet. For this patient on oxycodone, 1 milligram of morphine is equivalent to 1.5. 1 milligram of oxycodone is equivalent to 1.5 milligrams of morphine. So if we look at this patient's potential daily morphine milligram equivalents, if he's taking the low end PRN, it could be 35 morphine milligram equivalents per day, and at the higher end, 45 morphine milligram equivalents per day. So then we look at the patient's prescription profile in the system and notice probably a standard set of drugs. So Lexapro, Lipitor, amlodipine, and then clonazepam. So the one that jumps out that probably would need a little bit further assessment would be that clonazepam. As we've mentioned multiple times, the opioid prescription plus a benzodiazepine puts that patient at increased risk for an overdose. So to talk a little bit more about that, I'm going to hand it back over to Kelly.
Okay, so we've talked about this a lot, and thankfully I have some resources to refer you to read more about this. This slide in particular, though, is a more recent update on the data, which indicates the number of deaths involving benzodiazepines with and without opioids. So from 2002 to 2016, benzodiazepine-related deaths involving opioids has increased 6-fold. And if you note, the line at the bottom is benzodiazepines only, the grayish line. And so we want to be really clear that benzodiazepines by themselves rarely end in an overdose. It's the combination. And so you can see deaths involving benzos, and that may include alcohol or other CNS depressants, but in particular, the yellow line shows you that it's benzodiazepines in combination with opioids. That is our greatest risk in terms of what our patient is presenting with now. And so we want to be mindful of how to talk about reducing benzodiazepine doses and eventually discontinuing them. So I do want to refer you to a recently released pharmacist toolkit. It's called Benzodiazepine Taper, and it's through the College of Psychiatric and Neurologic Pharmacists. I'm happy to talk about that a bit more. It was just released, and it's a wonderful review on how to talk about reducing benzodiazepines and eventually discontinuing them, how to effectively taper them. So please refer to that. And so now we're back to the patient care process. And now that we've determined the risk associated with Jack's medications, it's time to devise a patient-centered plan that really includes you and the other members of his healthcare team. And so it's important that you decide what works best for you and your workflow at the pharmacy. And so prescriber communication may happen first. And so what you determine might be the best mode of communication, maybe a phone call. And that's okay if that works within your workflow, directly phoning the prescriber and discussing some of your concerns surrounding the combination of medications or even the morphine milligram equivalent of the opioid prescription. There's also other means, electronic communication or potentially via fax. This is an example to the right of this slide of a standardized form that you could consider using or building something like this that really allows you to directly communicate to that provider prescriber office and let them know some of your concerns. Maybe it's a duplicate therapy, maybe it's a high dose of an opioid, and that you would recommend naloxone be co-prescribed or co-administered with their opioid prescription. And so figure out what works for you, standardize your approach, and then we'll talk more about how to effectively communicate some of this to the patient. And sometimes this can be the most difficult part when somebody is taking a high dose of an opioid and they've been taking it for a long time. The idea of coming off of that can be really frightening for them. It can be really agitating or provoking. And so determining the best way to communicate this is really critical, especially in a community pharmacy setting. So what we know about after years of research involving patient and provider communication is that confrontational and directive approaches with regard to health information can build patient resistance and oftentimes poorer outcomes. And that more patient-centered, supportive, and empathic styles are really associated with much better outcomes. And so the question becomes, how do we do this? And also recognize that as a healthcare provider, as a pharmacist, we are in this field to do the right thing, to help our patients to be well. And so the righting reflex is something that comes natural for a lot of us. And that means that as a helping professional, we feel the desire to want to right someone's wrong, or to tell them how to improve their care, or tell them maybe what they're doing wrong and what they could do better. And there's this overwhelming desire to persuade someone to do the right thing. And this can become very frustrating. Patients often get defensive, and you've probably seen this happen. And the reality is they feel very powerless in their own care and in their own pain management. And examples of this might include if we say something to the effect of, you can't take these two medications together. And a response you might get back is, I've taken these medications together for years and I do just fine. Or if you don't stop misusing the pain medication, there's a higher likelihood that you could die. And again, it may lead to a defensive response of, well, I've taken these medications for a long time together and I'm doing okay. So being mindful of how we approach our initial encounter with the patient. So effective ways to engage in challenging patient scenarios. And really what you're going to find, so this is directly from the CDC. There's actually a module on communicating with patients who are taking long-term opioids. And this is very advantageous for nurse practitioners, pharmacists, physicians, anyone involved in the prescribing and dispensing of opioids. The first thing that we recommend is establishing trust. And this is such a big deal for a pharmacist-patient encounter. Patients trust their pharmacist. We establish that trust through active listening and through expression of empathy. And so this first step may seem simple, but really slowing down for just a moment and taking the time to hear what the patient has to say. The reality is we often feel very rushed, and we feel frustrated as well when a patient may be misusing an opioid. So approaching this with the idea that if we take a moment to actively listen to them and recognize that they're likely struggling, they're struggling to manage their pain, they're struggling to find a way to reduce their opioid. Recognize patient uniqueness. Recognize that the patient's culture, their experience, their social influences have likely dictated how their pain has been felt and how it's been managed over the years. We recognize that people who are often underserved, they may not have been given another choice besides an opioid prescription. Perhaps physical therapy or other modes of treatment weren't an option for them 5 years ago. And so we recognize that they were started on an opioid and now they're in a bit of a bind. Listen reflectively. And this is a big portion of what I'll talk about in a moment, which is motivational interviewing. When we listen reflectively, what we're doing is relaying back to that patient what we think we heard and making sure that we understand what they're trying to tell us. This is something we're going to actually practice in just a bit in a few slides. And then finally, showing empathy. And empathy really is about seeing the world through your patient's eyes and recognizing that they may have a legit pain condition. They may be scared. They may be terrified about the idea of coming off of a medication they've been on for years. And so motivational interviewing, you've heard me mention a fair bit. It is an evidence-based practice. It's widely utilized now by healthcare providers. However, it was initially developed many years ago by two psychologists in the context of addiction and the reality of this back and forth feeling that we struggle with when we want to stop something and potentially continue to use something, meaning a substance. So it's a patient-centered style of communication that explores that person's own internal motivations for decreasing or changing behaviors, meaning me telling someone to stop taking an opioid and telling them the reasons why they should is not going to be an effective way to see change. Really, that desire to change needs to come from within them and their own internal motivation. So helping them explore and resolve ambivalence. Those key features to motivational interviewing are on this slide. There's 4 pieces, and the first part is partnership. And so what I want you to think about here is a partnership that you have with your patient. As a pharmacist, you may be the expert in medication therapy, and the patient is the expert in themselves and their life experience. And it's really important that we collaborate with our patients and that it's not a one-sided dialogue. And that person feels much more accepted and a part of the healthcare team that is providing care for them. So we start with the partnership and then followed by acceptance. And this is a really challenging one for a lot of healthcare providers, which is accepting that people have autonomy and they have the self-worth and they can make decisions for their own healthcare. And that sometimes they're not going to make the same decisions that we would choose for them, but it's their life. And then evocation is drawing out from within that person's own self their reason for change. And finally, compassion, which is seeing the world through their eyes, but also having the desire to want to ease their pain and to help them to have a better life and wellness. Motivational interviewing may seem intense, and again, it takes a lot of training to get skilled with MI, but I want you to know that motivational interviewing could be done in 5 minutes, in 10 minutes. It can be very brief interactions, and it's very doable in a pharmacy setting. And so I was hoping we could talk just a moment about some difficult conversations that you might encounter. Now, having talked and had these conversations a fair bit with patients, these are some of the things that I've heard and some of the things that pharmacists that I work with have heard. And so I'd like to go over some of these comments, and I'd like to actually give you some ideas on how you could respond to some of these comments. So you might hear things like, you have no idea what this pain is like. And so what I would challenge you to do is think about, what is your patient trying to tell you when they say that? You have no idea what this pain is like. A reflection might be, you are in a lot of pain right now. And what we're doing by saying that is that we're letting them know we hear you. I hear what you're saying. I hear that you're in a lot of pain right now. And then let them respond to that. Or perhaps if you hear someone say, you have to give me this medication today. The reality of what they're trying to tell you is, you're worried that I may not give you your medicine today. You're worried about not getting your pain medication and what that might feel like. And that can be a significant anxiety-provoking experience. Or perhaps I ran out of my medication early because the doctor told me to take more. So the doctor may or may not have told that person to take more, but the reality is a response could be, you are doing everything you can to relieve your pain. And sometimes that means taking more of your pain medication. And then finally, another one that I hear a lot is, no other medications work. Nothing else works besides OxyContin or oxycodone. And so a response or reflection might be, it's hard to imagine what else could relieve your pain. You've tried everything else. And again, that gives that person an opportunity to respond back and say, yeah, I really have. And it's scary to think about trying something else. It's scary to imagine going back to physical therapy when I feel like it didn't work the first time. And so it may seem simple, and I know these aren't applicable always, but I really would encourage you to think about how you could effectively reflect statements back to a patient to really ease their mind and help them feel more heard. So on the next slide, what we want to focus on is ways to communicate opioid safety concerns. And so here are some comments or some statements that I would encourage you to kind of bring into your conversation with the person you serve. We know more now about the risks associated with opioids than we used to. And we know now that a high dose of an opioid medication poses a more significant risk, especially when taken long term. Let's work together to find a way to find a safer pain management plan for you that includes all of us together. Opioids tend to be less effective over time, and the risk of physical dependence, tolerance, and overdose increases over time as well. These are all messages that we can convey in an empathic way to our patients. It's also important to let folks know that when they are stopping an opioid, they will likely feel an unpleasant withdrawal experience. That can be muscle pains, nausea, vomiting, diarrhea, agitation, and they may have felt this already, and partly that's why they want to continue the opioid. Or they may take more of their opioid to reduce some of those withdrawal symptoms. And that for this reason, we recommend that gradual taper to get to a safer dosage and eventually stop. And that recommended taper varies. The CDC guidelines would recommend slowly at around 10% dose decrease per week. And that can be slower for some patients who have been on treatment for a long time. And then, of course, we want to discuss the non-pharmacological treatment options as well. So out the window, if we are mindful of all opioid prescriptions that go out of the pharmacy, we want to tag the bag and recognize that the pharmacist is going to need to talk to the patient about safety with their opioid prescription. This is an opportunity to talk about other ways to alleviate pain, to talk about non-pharm therapy, and also to talk about the side effects that may come with an opioid, including constipation, excessive sedation, and that respiratory depression that we're most concerned about when in combination with other CNS depressants. And this is the beautiful opportunity to talk about the role of naloxone, to ask them if they've heard of naloxone and if they would feel okay about walking away with a prescription or a medication, prescription for naloxone along with their opioid prescription. As I've started to pop into pharmacies and provide some education across the St. Louis region, I inevitably get concerns about how to bring up opioid overdose prevention in a pharmacy setting. And sometimes it can feel really uncomfortable. And so we'd like to show different ways to have this dialogue. This is an example of a pharmacist talking to a patient. And their comment is, I'm recommending that you get naloxone today. The medications you're taking can cause slowed breathing or even death. Naloxone is an antidote that you can keep on hand to reverse this situation. Is it okay if I provide this to you today? This is a wonderful way to approach this, and notice that I've avoided using the term overdose. And we found that when we're using prescription opioids versus street opioids, the term overdose can often be a bit scary to some people. And so figuring out a way to bring this up in a way that feels non-confrontational, but lets that patient know, I care about you, and I worry that you're taking a medication that's a bit more risky. So who should receive naloxone? We've talked about this in a previous webinar, but we felt the need to reiterate, anybody who comes into a pharmacy requesting naloxone should receive naloxone. It is critical that a family member has access to it if they have a loved one who's using opioids. If there's an opioid prescription in the household, that everyone has access to naloxone. If there are children in the household that have access or exposure to an opioid. But the CDC guideline or CDC would recommend anybody who's taking an opioid prescription that exceeds 50 morphine milligram equivalents per day. And some would go beyond that and say anyone who has exposure or access to an opioid. I would also add anyone who has exposure to an opioid and a benzodiazepine. And you might wonder, how would I approach that? I would say anybody who you're dispensing an opioid and a benzo prescription to is a candidate to at least talk about naloxone with them and hopefully dispense it along with. We also recognize if your patient is receiving opioid prescriptions from multiple doctors, multiple pharmacies, they are a candidate for naloxone. And if they have other health conditions, respiratory illnesses in particular, they are a candidate as well. Of course, anyone who's using illicit opioids, heroin, street fentanyl, they absolutely should be receiving naloxone. And to make this process easy, of course, I think everybody is very familiar with the statewide standing order, but we're finding that not everyone is utilizing it, or sometimes there's some confusion as to how to utilize it. So recognize that the statewide standing order follows under the director of the Missouri Department of Health and Senior Services, and that's Dr. Randall Williams. His information is on this slide. So if someone comes in and they are asking for naloxone, we can fill it under Randall Williams and under that patient's insurance. Most, if not all, insurances will cover, at least to a certain extent, naloxone. Missouri Medicaid covers naloxone or Narcan intranasal, and the statewide standing order covers the naloxone intranasal and the vials. Also recognize that a patient can come in and ask for naloxone and they don't have to give their name. They can just, you can fill it under Jane Doe, and they don't have to utilize their insurance. They can pay cash for it, and some people may choose to do that. So we would document that for distribution. So this is actually some really good news on this slide. What we wanted to share with you was a survey that was done through Opioid STR and the Missouri Board of Pharmacy before the statewide standing order came about. And what we learned, and you can see the different colors recognized 2017 versus 2018, that pharmacies were stocking naloxone prior to the statewide standing order were about 50%. After that, a year later, it was closer to 85%, which is huge. The take-home message I would say from this slide is that every single pharmacy should have at least one naloxone product on their shelves, because the reality is if a patient comes in and asks for it, the likelihood of them coming back and giving you time to order it and have it the next day and them coming back to the pharmacy is much less likely. So please stock naloxone in your pharmacy, and we were so excited to see this number jump. Also, the number of pharmacies currently receiving training for naloxone increased significantly from 27% to 66%. And here is a perfect opportunity to let you know that we still are offering trainings on MAT, on naloxone and opioid overdose prevention, and we'll have information on how to reach out to us at the end. So back to our patient, Jack, and this is 6 months later. What we noticed with Jack is in the PDMP, it's rather alarming. He's got 3 physicians now in 6 months and multiple pain medications. And now he's taking oxycodone 10 Q4 hours and OxyContin as well. So now we've gone well beyond that 50 morphine milligram equivalent daily. And in conversation, he does acknowledge that he has a problem, and he asks you about treatment options. So here's where I think sometimes pharmacists feel in a bit of a bind, and they're not sure how to move forward with this. So in following the effective communication process that we talked about, utilizing your motivational interviewing skills, we would recommend that you do elicit, provide, elicit. And so what this looks like in a clinical setting, and again, it can be 5 minutes of elicit information from the patient. So from Jack, tell me more about your pain management. Tell me about your experience. Tell me what you would rate your pain at now, and tell me about how you're taking your pain medications. Also, I'd like to know how you stay safe, or do you know about how to stay safe while taking opioid pain medications? And so then we listen. We listen to what Jack has to say about his own personal experience, and we get to the next piece, which is provide. The critical part here is when we provide new information, we should ask permission first. And how that looks is, would it be okay if I tell you a little bit more about what I know about opioid prescriptions or the safety concerns that I have about opioid prescriptions? And when we ask permission first, it gives that patient the autonomy to say, I don't really want to hear about it today, or yeah, I would love to hear more. And the reality of it is when we ask permission first, the majority of people welcome that information. So we ask permission, we say, would it be okay for me to tell you about the concerns I have about the dose you're taking with your opioid prescription? I'd like to tell you more about opioid safety. I'd like to talk about the side effects with you, and maybe a little bit about what we call harm reduction or ways to help keep you safer. Once we do that, now it's an opportunity to say, to find out what Jack thinks about what we've said. And so this is what the second elicit, which is new information. So what are your thoughts about what I just told you? How do you feel about a prescription or about taking naloxone home with you? And so the reality is what we're trying to do is reframe your interaction to a more person-centered dialogue rather than providing that expert opinion that we often do, because we do have a lot of information that we would like to share with the patient. And then finally, if you are feeling like you would like to do more, you would like to recommend treatment options for Jack. Jack is telling you, I'm concerned about this. I don't know how to stop. Perhaps you've talked to the prescriber already, or maybe Jack's talked to the prescriber already. We have a wonderful list of opioid treatment programs across the state. They oftentimes also accept patients without insurance, so that shouldn't factor into where they initially can go. And so I know this is a little hard to read on this slide. This is a front and back side of a PDF. It is available at the MissouriOpioidSTR.org website. And what you can find on here, or have the patient look what region they live in and what treatment centers might be most appropriate for them. This would be an opportunity to potentially figure out how to come off of an opioid prescription, potentially start medication-assisted treatment or something like Suboxone. Additional helpful resources. So there are several, and again, with the opioid overdose crisis that we are in, you are constantly going to be seeing new resources come out. So look for those. I would encourage you to look at the Center for Disease Control and Prevention, evidence-based strategies for preventing an opioid overdose, but also what I've talked about earlier, the guidelines themselves. CPNP, which I mentioned earlier, has the benzodiazepine taper toolkit. They also released a harm reduction strategies for people who inject drugs, considerations for the pharmacist. So I would encourage you to also take a look at that. If you're more interested in learning about motivational interviewing and how to effectively engage patients in an empathic way, I would refer you to Dr. Miller and Dr. Rolnick's 3rd edition of MI, Helping People Change. There's also plenty of editions that focus on healthcare providers as well. We've talked about Prescribe to Prevent and Prevent to Protect in the past. Prescribe to Prevent is an organization nationwide that offers resources on harm reduction, and Prevent to Protect is specific actually for pharmacists. They're great resources. Links within Missouri, we would encourage you to go to the Missouri Board of Pharmacy website, but also we've mentioned several times the Missouri Opioid STR website, which has all of the resources that we've established over the last year and a half through our pharmacy consult team. And this is also a place where you can request if you would like to learn more or if you would like more resources. So we would encourage you to reach out to Lauren Green, and her email address is on this slide and her phone number as well. We've been calling pharmacies and offering pop-in or drop-in education sessions. We want to encourage you to reach out to us if you're interested in learning more about Suboxone, methadone treatments or MAT, motivational interviewing, harm reduction, the PDMP, or naloxone rescue treatment. All of these could be put into small 15 to 30 minute sessions that we can offer to you online or in person. And so reach out to Lauren Green if this is something you're interested in. We are also planning to record in the next 2 weeks what we call a fireside chat. And this is going to be a dialogue between a family medicine physician and a pharmacist. And the hope is that we engage, or they engage, in questions that you frequently come across in your setting. So if you would like to submit questions to us, we would really appreciate that. We would love to hear some concerns you have about how to engage physicians when you have concerns about the PDMP, and then we'll have that physician address some of those questions in the fireside chat. When to consult with a physician, all of these, I think, would be beautiful things that we could hear from you to make this fireside chat more effective. And so I think we are close to the end.
Yeah, just to reiterate what Tom said, the college will be emailing information about CE credit and how that is obtained. So be looking for that this week, and certainly let us know if you don't receive that. And with that, we'll wrap up, and I'll let Tom wrap up with a few things, and we may have just a few minutes available for questions.
As I switch over to my screen, I just want to remind everyone there will be no survey after the program today like we normally do, since the CE is coming through still COP. You will not get a survey, so don't be looking for those questions to come as we end the webinar. So if you have questions, please go ahead and send them using your toolbar there. Amy, are you able to see the questions on your end?
Yes, I can.
Okay, and I forgot to tell you, you can pull that off to enlarge them. You can pull
I'm working on that right now.
the tab out. Okay.
Yeah.
So I'll let you guys pick the ones you want to answer. while they're reviewing them, I will just, someone's asked, are the slides available? We have handouts on our website. If you want an actual presentation, you would need to email me and I will see if we can actually get you a copy of the PowerPoint.
So there were a few questions I'll answer real quick about the 7-day supply. If the patient's been on that medication before, but it's a dosage increase, that would not be considered a new medication. So that technically probably doesn't fall under it, although I would say would require monitoring if you had something, a prescription for an acute pain that the treatment was going beyond that, to maybe have some of those dialogues, or at least be aware that that might be going into a chronic pain picture. And then the documentation for physicians who prescribe greater than 7 days, that can be done verbally with a phone call. I know many times, I think the physicians are still getting used to probably documenting this for you, so you know when you get the prescription. Ideally, it would be great if they put on the prescription, but that's probably not happening. So that verbal documentation that you have talked to someone at the physician's office and confirmed those exceptions for that prescription is acceptable.
And while Amy is looking through some of these other questions, we saw some questions from previous webinars that I was hoping to address as well. Somebody asked, how does a pharmacist handle a patient being prescribed above the 50 morphine milligram equivalent recommendations? And there's lots of ways you can address this. First and foremost, I would say it's absolutely okay to verbally have a conversation with the prescriber, express your concerns, talk to the patient about that, and absolutely it's time to have a conversation about opioid overdose prevention and offer naloxone prescription.
There was a question about the prescriber communication form. That is something that we developed, and we are happy to make available for anyone. If you want something that you can take and modify or just use as is, we'd be happy to provide that. So that is available. You can contact Lauren Green, and we can get that to you.
There was a question in the past about how can I find free CE for physicians, or are there programs that we can recommend for physicians as well as pharmacists and nurse practitioners? The Provider Clinical Support System, or PCSS, provides evidence-based training and resources for opioid use disorder as well as pain management.
With regarding to the PDMP usage, the St. Louis County PDMP folks monitor that. I know that there have been times when not all of the data is submitted like it's supposed to be, so they work and contact those pharmacies directly about making sure that they're in 100% compliance with submission of data. So if you are seeing those consistently, you can certainly contact the St. Louis County PDMP folks and let them know. But they are aware that sometimes it just takes a little while for them to work with that pharmacy to get that full data set available. But we've seen that especially when a county initially implements that, sometimes you're not getting every single prescription from every single pharmacy, but that is regulated and that is mandated. So that will, they will continue to work on that until they are in compliance.
Question, what was the name of the benzo toolkit? It's called Pharmacist Toolkit Benzodiazepine Taper, and that is available through CPNP, which is the College of Psychiatric and Neurologic Pharmacists, and their website is cpnp.org.
There's a good question here about how we see these conversations translating within the inpatient space, and that is definitely an area where we think pharmacists have a role as well. Certainly, if the patient came in related with an opioid event, there's a lot of motivation there to have those conversations because that's what they came in for. But even if it's identified outside of the main primary reason that the patient is in the hospital, that at a transition of care or pharmacy rounds, wherever that might be, I think there's a lot of different places where it can happen. And again, it depends on how the pharmacists function within the setting. It could potentially be, a transition of care, ideally to a community pharmacy that is active in this and can help support the patient in that as well. That would be a really great warm handoff and transition of care for that patient. But there aren't any guidelines or modalities for that yet, but I think that's something that we're looking at and hoping to really formalize more in the future.
And just to be clear too, the skills of motivational interviewing, the communication style, it can be utilized inpatient, outpatient, clinics, community pharmacies. Any of those areas could include an MI specific conversation.
For the fireside chat, that's something that the Missouri Opioid STR grant will be recording. So we've identified a pharmacist and a physician that will come together and kind of talk through some of those issues. That will be available when it's done on the Missouri Opioid STR website, which we provided the link for. If you had a question or a specific barrier that you feel like you have in talking with physicians about these issues, that's where we'd love for you to put that in the chat box for this presentation, and we'll pull all of those and incorporate those into the questions and the format for the fireside chat.
Next question is, where can patients get free naloxone if they cannot afford it? This is more specific to the St. Louis region, but NCADA offers free naloxone, as well as the Missouri Network for Opiate Recovery and Reform, which is Robert Riley and Chad Sabora. And so you can recommend, which is over on Broadway in St. Louis City, you could recommend those two places to get it for free.
I think the Opioid STR website also lists locations statewide that have free naloxone available.
Someone was asking for Lauren Green's contact information, so I pulled that slide back up for you.
Thank you.
Yeah, it's lauren.green@mimh.edu. So update on the statewide PDMP legislation. I think actually today, Holly Rader, and I apologize, I forget the other legislator, we're going to file for statewide PDMP. I think now that we have more than 80% of the state's population covered with the jurisdictions that are participating, that provides a much stronger case for moving that legislation through from a statewide perspective. Obviously, it's legislation and politics, so we'll have to see what happens with that. But so that you are aware, the county PDMP system is designed such so that if the state does approve a statewide PDMP and they decide to go with that same vendor provider, that system can be rolled out to a statewide system very easily. So that would obviously be the most ideal, but we are definitely keeping our eye on that. If the county PDMP system is more accessible or provides more information than what a statewide system would, that county PDMP would still stay in place in addition to the statewide system. There's a question here about, do Missouri pharmacists need MTM, medication therapy services designation on their license to execute the naloxone standing order? And the answer to that is no. The standing order is essentially a prescription that is written for anybody in the state of Missouri to be able to access naloxone. So even though they don't have a physical prescription or an e-prescription coming in with their specific name on it, that standing order stands in the place of a prescription, and for dispensing purposes, you don't need any additional qualifications in order to be able to dispense that medication at the pharmacy counter. And then one final question, is Missouri the first state to adopt something like SB 826? The answer to that is no. That's a fairly common thing that's happening legislatively across the country. The parameters around that vary. For instance, I think Kentucky actually has a 3-day limit versus 7-day limit. And so because, especially in states where the opioid crisis is hitting especially hard, that these legislations are likely already in place, and if not, they are on the legislative docket for this year in most states.
Well, it looks like we're about out of time. I want to thank Amy and Kelly for presenting today, taking the time to prepare this and present it today for us. Very informational. The board will try to put out some of the information on the fireside chat and other things that Kelly and Amy talked about today. So watch for email alerts for information like that. So we're now going to close our webinar. Again, there will be no post-webinar survey, so you will not get the screen of questions from us as you normally do. So again, thanks for joining the webinar today.